Hello, everybody, and welcome to this episode of GU Cast, which I have to say I am very excited about. This is a first for us. It's the first in a new series of GU Cast that we'll be bringing to you every month, and we're calling it GU Cast Journal Club. That's right. So we're going to do a proper full-on journal club, ideally aimed at trainees in GU Oncology, in Urology, Radiation Oncology, Medical Oncology, Nuclear Medicine, Pathology, whatever. If your interest is in GU Oncology, and especially if you're a trainee and maybe you're preparing for exams, well, then Journal Club is for you. Or if you're someone who is wants a refresher and maybe your practice is mostly based on bladder cancer or kidney cancer, watch out for these GU Cast Journal Club episodes. We'll be posting one every month. Now, Renu is not with me today. She is doing other stuff, but she will be here normally. But I am joined by two guests who are going to be running the GU Cast Journal Club over the next few months, at least, if I can convince them to stay on, and I'll be introducing them in a minute. But before I do, I will also acknowledge our partners, MSD Oncology, who are supporting the GU Cast Journal Club. They are a very important partner of ours in GU Oncology, supporting education and lots of stuff we do. Pembrolizumab is one of the drugs that they look after. So we're very grateful to MSD for supporting the GU Cast Journal Club. So yes, here in studio, if you're watching on YouTube, I'm joined by Dr. Carlos Delgado. Carlos, how are you?
Good, and yourself?
I'm very well. Well, thank you for joining us in the studio.
Finally, here in Melbourne.
So Carlos has just joined us to do a fellowship here at Peter Mac in Melbourne. He's a senior urology trainee from Mexico City. Well, you have been in Mexico City, but tell us a bit about yourself first of all, and where did you train, and where have you been, and so on.
Great. I grew up in Tampico, which is a small city in the northeast of Mexico. Then moved to Monterrey to do med school and residency training there. I completed it, and after that I moved to Mexico City to do a fellowship at the National Cancer Institute in Mexico City, Urologic Oncology fellowship, and then I just moved back here.
To do another fellowship in GU Oncology.
Of course.
Okay, so that's clearly your... Well, you're very welcome, and you've literally just landed in Melbourne yesterday or something like that. So.
Yeah, a few days ago.
Very good. So before he even sets foot in the Cancer Centre, we've dragged him into the GU Cast studio to be on the inaugural GU Cast Journal Club. So thank you for joining us, Carlos. And now let's go to Munich in Germany to our other GU Cast Journal Club host, who is Dr. Elena Berg, joining us from Munich. Elena, good morning to you.
Good morning.
And thank you for joining us. We're very excited to have you here on the GU Cast Journal Club. Now, I know you for a few years. I know that you're a friend of the podcast, as we would say. You even traveled down to Australia, I recall, and came up to us at one of our scientific meetings here and explained to us that you find GU Cast helpful when you're preparing for your exams and so on. And so we thought you'd be the ideal person as a senior trainee in Germany in the EAU system to join us on the podcast. So thank you for joining us.
Yes, a pleasure to be here. Thank you.
So likewise, tell us a bit about yourself. And now you're at the end of your training as well, I gather. So where have you trained and what are you up to now?
Yeah, exactly. So I'm in my final year of training. I'll hopefully finish training in September this year. And I trained in Munich at the Ludwig Maximilians University, went to medical school here, and then joined the urology program. I spent some time in New Zealand and Australia during uni and work. So I visited you down there sometime. I have been focusing mainly on GU Oncology and want to go on with that in the future.
Excellent. Well, best of luck to you. I think you're doing your final exams coming up at the end of this year as well. So perfect timing. So a bit about the format of the Journal Club. And we're wide open to suggestions. So if you have ideas for how we can tweak this or do it, please do get in touch with us at GUcast in all the usual ways. But each month we're going to feature two papers that would classically feature in any journal club that any of you are familiar with. These will be papers focused on GU Oncology, obviously, that's what we do. I think mostly they'll be papers from the relatively recent past that we want to draw attention to educate ourselves about. But we want to do a critical appraisal of them as well, the strengths and the weaknesses and how they might inform practice. And unlike many other normal episodes of GU Cast, where we're inviting on the authors of those key papers as they come out, in this we just want to, keep it between senior trainees and ourselves, like a classic journal club, and we may have special guests who might join us as the months go by. So we've worked together, Carlos and Elena and Renu, to pick out the two topics for this month. The first of which you're going to present to us as we discuss, Carlos, and this is in European Urology recently. It's called Active Surveillance for Screen-Detected Low and Intermediate Risk Prostate Cancer. It's the extended 25-year follow-up from the Göteborg 1 trial. So you'll tell us a bit about that, but we do agree that this is a very important, it's a landmark trial anyway, the Göteborg study. It's important we all know about it. But this is extraordinarily long follow-up to tell us a bit about the natural history of active surveillance. So I think this is very important for us to know about. And the second paper that Elena will deal with is a bladder cancer paper, a really important paper published in New England Journal of Medicine last year. It's the SWOG 1011 study, standard or extended lymphadenectomy for muscle-invasive bladder cancer. Now, we did deal with this after it was presented at ASCO, I recall, a couple of years ago, but we haven't actually dived right into the paper, so we're very much looking forward to that. So shall we get started?
Sure.
Let's do that. So Carlos, we're going to hand over to you. We're going to have about 10 to 12 minutes, I think, for each of these papers. We'll try and wrap it all up in about 30 minutes. And you can tell us about this Göteborg study paper. And of course, the links to the full papers will be in the show notes. We don't intend presenting the whole thing. It's like key messages and so on. And the links are in the show notes. Over to you.
Perfect. Well, to set up some background, the Göteborg 1 trial is a landmark randomized study that demonstrated a 41% reduction in prostate cancer-specific mortality with PSA screening every 2 years over a 20-year period. It definitely confirmed the benefit of early detection, but it also raised some concerns about the overdiagnosis and overtreatment, particularly of lower risk disease. So these findings laid the groundwork for exploring active surveillance as a strategy to balance early detection with minimizing harm, and setting the stage for the 25-year follow-up data now available on patients managed conservatively. As we all know, this strategy has been used several decades, showing low mortality rates around 1 to 4%, with up to 15 years of follow-up until now. The aim of the study was to evaluate long-term risk beyond 15 years of missing cure and dying from prostate cancer for men with screen-detected prostate cancer managed with active surveillance. So let's go on the methods. 488 men with a screen-detected prostate cancer in Göteborg 1 screening trial managed with active surveillance were included. Among these patients, most of them were very low risk, 251, 129 were low risk, and 108 were intermediate risk disease. PSA testing was performed every 6 to 12 months, and repeated biopsies were indicated if there were signs of clinical progression without any active surveillance, formal active surveillance protocol. Let's remember that it was done in 1995, where active surveillance was not even a thing.
Yeah, there wasn't any such thing as confirmatory biopsies and certainly no MRI scanning.
Correct.
Okay.
Kaplan-Meier analyses were performed for treatment-free, failure-free, and prostate cancer-specific survival from diagnosis to an event or last follow-up. After a median follow-up of 18 years, a total of 232 men discontinued active surveillance, 81 experienced failure, and 14 died from prostate cancer. Treatment-free survival rate at 22 years was 38% for the entire cohort, being lower among patients with intermediate risk disease. Failure-free survival rate at 22 years for all men was 68%. Noteworthy, nearly half of failures occurred 10 years after diagnosis. And it's important to define this. They define failure as non-curative PSA relapse, starting hormonal treatment, metastasis, or death due to prostate cancer.
Okay, so that was failure. Remind me again, what was the failure-free rate at 22 years?
Was 68%.
Okay, so 68% of people we're still alive and living well without failure from.
Okay. Without having a non-curative PSA relapse. Okay. Gleason score showed to be the strongest predictor of failure, and prostate cancer specific survival rate at 25 years for the entire cohort was 94%, a bit lower compared to other studies, but still, this is a 25-year follow-up. This is the largest cohort of active surveillance patients up to now. All 14 prostate cancer related deaths occurred in men who had already received treatment during follow-up. And well, as part of the discussion, even though outcomes for treatment and failure-free survival appeared to favor men with lower risk prostate cancer, the risk of treatment and failure remained constant over time for all risk groups: intermediate, very low risk groups, and low risk groups. Many men switched to treatment, but a large proportion missed their chance to achieve cure by postponing treatment. Mortality outcomes is consistent with other trials. Protect trial had 3.4% of mortality. Toronto active surveillance cohort had 5.7% of mortality after 15 years of follow-up. We are seeing here a bit higher, but this is a 25-year follow-up. The main strength of the study is that this study presents the longest follow-up of men with screen-detected prostate cancer managed with active surveillance. And of course, the limitations main limitation is that there was no predefined surveillance protocol used since active surveillance was not a well-defined strategy in 1995 at the start of the trial. Also, the regimes used for these patients followed in active surveillance were less intense than what we do nowadays. And there was also a Gleason score update in 2005, which maybe would a lot of these patients, a lot of these tumors would have been reclassified as intermediate risk instead of low risk cancers. Also, of course, there was a lack of MRI for diagnosis, which is unthinkable nowadays. Do active surveillance without MRI, and this may have implied a risk of undersampling and undergrading of tumors. And take-home messages. I think patient selection remains the key for active surveillance success. Patients need proper monitoring, continuous follow-up during a very long time period, so we don't miss the possibility of cure. And it is essential to inform our patients that they will require follow-up for many, many, many years. It is very resource demanding, even with modern screening setting, like the one seen in Gothenburg 2 with MRI targeted biopsies only. Around 30% of all men diagnosed with prostate cancer were recommended active surveillance. So I think this is not suitable for low-income countries where MRI access is not widely available.
Very good. I know you want to talk about what the EAU guidelines say, but let's stop there for a moment, Elena, and have a think about that. So what are the take-home messages from this Gothenburg 1 up to 25-year follow-up thing? Numbers that jumped out at me were 94% prostate cancer specific survival. So that's still very good. If we have a screen detected population and we're going to include, pretty liberally low and some intermediate risk, quite a few intermediate risk patients, like a quarter of the patients in the study are intermediate risk 25 years ago. That was
very forward thinking.
Yeah, exactly. And many of them would be probably 4+3s actually nowadays unfavorable. Yeah. But number one, overall, the prostate cancer specific survival is very good. So a key message is, of course, surveillance is a good thing. But number two, there were quite a lot of failures as they defined as, PSA as being very high, outside cure rate, metastases or hormonal therapy and so on. So I suppose the question within that is, well, how do you get that number lower and probably have the prostate cancer specific mortality higher? And I don't know, we might go to you, Elena, and ask you about this. Do you think that in the modern era where people are being very well selected for active surveillance, they're having MR pre-biopsy and they're having, really targeted biopsies, you're not underestimating disease. In some countries, there'll be some genomic testing on the original samples as well. People might be having a PET scan to show minimal avidity. Do you feel that these numbers will be even better, because these are good numbers in the modern era, if you're looking 25 years forward from patients you might be seeing in Germany this week?
Yeah, definitely. I mean, we have the MRI, the diagnostic pathway has changed a lot in those years. So we will probably see less patients with this failure. And I think the group we really want to have a look at is still the intermediate group. We know intermediate, they are good for active surveillance as well, but we really have to monitor them very carefully and have a very strict patient selection for those patients.
And Carlos, you said at the start in your background to it that the Berg study, it was part of the ERSPC, of course, wasn't it? And when that ERSPC screening trial, which we must include in a journal club at some stage, that pivotal study in 2009 when it got published in the New England Journal with the PLCO trial, it said, great, screening does seem to reduce mortality, but the key concern was over-detection and over-treatment, and it led to actually decreased early detection really around the world for a few years. So the message was, okay, but there's quite a high price to pay for over-detection and over-treatment. So is that what studies like this are, a way of looking at that to say that the mitigation is, not everybody who is screen detected is going to be having treatment for prostate cancer. They can be surveyed.
I agree. I think that the problem is still over-treatment, not very much over-diagnosis. Yep. And nowadays that we have MRI, we can cut down quite a bit over diagnosis.
Yeah, because if the MRI is normal, you're often not biopsying, and it means that those patients probably have a bit of grade group 1 cancer, but you don't even know about it. So yeah.
But this is very reassurance that nowadays with all the technology we have, we can safely monitor these patients for a very long time.
But Elena, some people might look at this, some patients might look at this and say, but I'm concerned about that failure-free rate. I don't want to be on hormonal therapy. How can, this Berg study in European Urology is telling us that there is quite a bit of failure, even though the overall mortality is quite low. That's prostate cancer in a screen-detected population. Can you reassure your patients you think that modern methods will mean these failure rates will be even lower, so that more patients will still end up in a curative state?
Yeah, I think that is important information, and that's definitely what we need to tell the patients, that active surveillance is something that needs lifelong monitoring and that needs close monitoring, and we'll try to reduce those failure rates with all that we have, biopsies, MRI, and so on. But they need to know that this really is long-term, lifelong monitoring if they choose to do active surveillance.
Very good. And as we're going to probably do with nearly all the papers we're going to discuss on GU Cast Journal Club, EAU guidelines are our favourite guidelines. They are certainly our endorsed guidelines here in Australia, as they are in Europe. Do you use EAU guidelines in Mexico and across South America? Yep, they're the go-to ones, aren't they? So we're going to try and refer back to, what do the EAU guidelines say about this particular topic? So I know you went and had a look at them. So, and we're particularly interested in intermediate risk, as Elena just said. So what do the EAU guidelines tell us nowadays as we wrap up this paper?
So they do a weak recommendation on intermediate risk, active surveillance for intermediate risk. And they say that we should offer active surveillance to selected patients with ISUP grade group 2 disease, less than 10% pattern 4, PSA less than 10, CT2A disease, and low disease extent on imaging and low extent of tumor biopsies. This means less than 3 positive cores with Gleason score 3+4 and less than 50% cancer involvement per core. Or another single element of intermediate risk disease with low disease extent on imaging.
Okay, so would you agree, Elena, we can include we call that now favorable intermediate risk prostate cancer. Really, I think what you've just read out there is what in the new, in the EAU guidelines this year, they introduced favorable and unfavorable intermediate risk. So it seems to be, that category, favorable intermediate risk, which is kind of what you summarized there, grade group 2, not grade group 3, less than 10%, less than or equal to, I would say, 10% pattern 4, PSA less than 10. I don't know. Sometimes we'll let PSAs go a bit higher than that in our practice. Low disease extent, and that's they've made that deliberately a little bit vague. So not the entire prostate has got 12 millimeter cores of grade group 2 cancer. So broadly speaking, that's a category of patients that can be offered surveillance, provided we're all very well informed. Would you agree, Elena?
Yeah, definitely. Yes.
And the other one that's in the EU guidelines is from a pathological subtype point of view. They do specifically. It's not. Isn't it? There's something about cribriform, isn't there, or IDCP?
Correct. They say this is a strong recommendation against.
So if you have cribriform pattern
or intraductal carcinoma, you shouldn't have those patients in active surveillance.
Very good. I love it. Great paper. I really like that. The active surveillance for screen detected low and intermediate risk prostate cancer, 25-year follow-up from Göteborg 1 in European Urology recently. First author, Amelie Palmstad. I see our old friend Jonas Hugesson in there, and Rebecca Ernsrud Gottman, Marianne Madsen, all as part of that Göteborg 1 group. So love it. Well done. Good job. Done. The first paper on GU Cast Journal Club. Elena, over to you. And the other thing Renu made me promise is that we're never going to do 2 prostate cancer papers on the one episode of GU Cast. I mean, there's a lot of prostate cancer oncology papers out there.
This should be hard for you.
Exactly. It should be hard for me. Thank you very much. And that's a promise to ourselves. There will be no more than 1 and maybe occasionally 0 prostate cancer papers in GU Cast Journal Club. So I'm very happy we have a bladder cancer paper. And look, I think this is like one of the most important surgical bladder cancer papers that there has been. And what it is essentially a negative study, as Elena will tell us about. Sometimes it's very important to do a prospective randomized trial, and you end up coming away from that. Oh, we should not do that, and that's what this is. So this is the standard or extended lymphadenectomy for muscle-invasive bladder cancer. So the presumption is that all patients undergoing cystectomy should be undergoing what is variably defined as a standard pelvic lymph node dissection. But what about doing a more extended lymph node dissection? Would that improve disease-free survival? So this is the SWOG 1011 study from the US, first author Seth Lerner. Okay, Elena, over to you. Tell us about SWOG 1011 in the New England Journal of Medicine last year.
So the background of the SWOG 1011 was that we know lymph node dissection is standard during radical cystectomy for muscle-invasive bladder cancer, but the optimal extent of dissection has been debated, and extended pelvic lymph node dissection has become standard of care in many centers, even though there were no prospective randomized trials to compare this approach to a standard approach. And it was mostly data from retrospective studies that reported a survival benefit of the extended approach. So the goal of this trial was to evaluate whether there is an oncologic benefit for the extended pelvic lymph node dissection versus the standard approach, and in a prospective and randomized setting, and also to see if complication rates, morbidity, and mortality vary between those 2 approaches. So patients with muscle-invasive bladder cancer, T2 to T4A, were included, and they had 2 or fewer positive nodes, and they were randomized intraoperatively to receive either extended or standard pelvic lymph node dissection. Standard was defined as the removal of the internal and external iliac nodes, as well as obturator nodes. And extended was further the removal of the common iliac nodes pre-sacral, pre-sciatic, and it was allowed to go up to the mesenteric inferior artery and remove the pre-caval or periaortic nodes. Patients were allowed to have received neoadjuvant chemotherapy, and they were allowed to receive adjuvant chemotherapy. And a very special aspect of this trial was that surgeons needed to have performed at least 50 cystectomies over the past 3 years, and 30 cystectomies needed to be performed at the participating hospital per year. and the surgeons needed to send in intraoperative pictures, photographs. They needed to send in surgery reports, pathology reports before they were allowed to enroll patients, and also during the trial. The primary endpoint was the disease-free survival, and secondary endpoints were things like overall survival, morbidity, mortality, surgery time, hospital stay length, histopathologic features, and lymph node count. They included 592 patients, and they received surgery by one of 36 surgeons at 27 sites. Most of them had clinical T2 disease, and 57% had received neoadjuvant chemotherapy. The median number of nodes removed was 24 in the standard arm and 39 in the extended group. But the percentage of patients with positive nodes was quite equal, with 24 in the standard group and 26 in the extended group. And so was the median number of positive nodes with 1 and 2 respectively. When we come to the primary endpoint, the 5-year disease-free survival did not show a significant difference and did not show a benefit for the extended pelvic lymph node dissection, with 56% in that group versus 60% in the standard group. And the same was apparent for the overall survival, with no benefit for the extended approach. It was 59% in that group versus 63% in the standard group. But the adverse events grade 3 to 5 were higher in the extended pelvic lymph node dissection group, with 54% versus 44% compared to the standard arm. The most common ones were anemia requiring blood transfusions, ileus, thromboembolic events, wound complications, and infection or sepsis. And interestingly, death within 90 days after surgery was more frequent also in the extended arm. It was 19 patients that died during this time versus 7 in the control group. And the majority of those deaths occurred due to postoperative complications. So in conclusion, the extended lymphadenectomy during cystectomy did not show a benefit for disease-free survival or overall survival, but it was associated with higher complication rates and higher mortality.
Wow. What a great summary, Carlos. All right, and if you missed a bit, or you were distracted by a dog running across the park, just rewind 3 minutes on your Spotify and listen to what Elena just told us. Yeah, that was stunning. So of course, I suppose the authors thought there probably was going to be a benefit in DFS and the disease-free survival, and a really, really high quality study, wasn't it? As you pointed out, they built in all these quality control measures to make sure people were getting the surgery as planned and you saw it in the results that way more lymph nodes, 39 versus 24. They're sending in photos and videos of the templates to prove it and so on. So there's no question about the quality of the study. But guess what? You take out a lot more lymph nodes and it does not, number one, improve your disease-free survival or your overall survival. And in fact, it leads to, very significantly worse outcomes in terms of major complications and even deaths. I mean, it's worth reading out those numbers again of a study of 592 odd patients in the 90 days after study. 19 patients died in the extended lymph node dissection arm versus 7 patients in the other arm. As a sobering reminder of the scale of this surgery and the fact there's a mortality rate, but it's way worse if you do an extended pelvic lymph node dissection.
Almost 3 times more. Almost 3 times more,
And, you do wear a little bit of extra complications if there's a really significant overall benefit for something, don't you? Like same for oncology drugs and so on. This predicted toxicity, you're at risk of this. But if you're going to live longer, if improve your survival or improve your quality of life, there's a certain amount of that cost of complications or even a mortality rate that you might wear. But in this, clearly nothing. Yeah, so amazing study, and it should be absolutely recorded as a practice-changing study in urology, I think, Elena. What's your take on it? Strengths and weaknesses and impact in practice and so on.
Yeah, as you say, it is a very well-designed surgical trial. We did not have as many randomized controlled prospective trials in this area. Those surgical templates, they were well defined, and as you say, this very strict credentialing process with surgeons having to send in those photographs, surgical reports before and also during the trial. That was a very special aspect. What I also think was a strength is that they allowed neoadjuvant chemotherapy. That is a realistic setting and is an important clinical message because there was no association between what kind of lymph node dissection patients received and the disease-free survival, depending on whether they had or had not received neoadjuvant chemotherapy. So that is interesting. We had this other trial here from Germany, the LEA trial, that did not allow the neoadjuvant chemotherapy and that did include patients of more favorable risk as well, for example, PT1 tumors. So this is new information. And I think it was hard to find any real limitations in the study. Of course, surgical techniques and perioperative protocols have evolved a bit since the beginning of the study in 2011. So there were no robotic cystectomies in the study, only open approach was allowed. But this should not in any form depend on the surgical approach. It is a disease mechanism that we're having a look at. The results, of course, reflect the surgery in academic high volume centers from high volume surgeons. Then things like ERAS protocols evolved in that time, but were not standardized at those centers yet. So maybe we would expect that adverse events rates would be a bit lower nowadays with ERAS protocols implemented. And we have to ask ourselves, what do we do with people with N2 or N3 disease and a high amount of ferrine histology, for example?
So, Carlos, if you're a trainee out there this morning and you're in Europe and you're cycling into the center and there's a radical cystectomy on the list, and you know the boss loves doing extended pelvic lymph node dissections and he or she is an expert at doing this, but you know, as soon as they get anywhere near the common iliacs and you need to say, excuse me, sir, excuse me, doctor, excuse me, ma'am, and put it, I'm terribly sorry, you know, you are not allowed to do it. Because, you know, many of us who've done a lot of pelvic lymph node dissection enjoy the operation. It's such a lovely anatomical operation. And when we had Sia Danishmand, who's one of the senior authors on the study, talking to us about it, he said it's like that, you know, it's like it's difficult to stop. I feel I'm doing the right thing, but guess what? A rigorous surgical trial presented in ASCO plenary and published in the New England Journal of Medicine. They said, yeah, the fellows have to, you know, put a clip there and say, stop, you're not going any further north of here, the pelvis, please.
It's hard to stop doing something that you were taught to do.
Yeah, and look, it's huge congratulations to those authors, Dr. Seth Lerner, Sia Danishmand, Ian Thompson, senior author and the SWOG S1011 team. So, Elena, what about the EAU guidelines? So this paper came out, New England Journal of Medicine 2024. The link's in the show notes. Have you had a look at the guidelines? What do the guidelines tell us about the evidence for pelvic lymph node dissection in bladder cancer?
Yeah, so the guidelines have mentioned those two randomized studies, and they recommend to perform lymph node dissection as an integral part of radical cystectomy. But they say perform standard lymph node dissection, as extended lymph node dissection has been shown to not improve survival and to cause mortality and morbidity. So they've implemented that.
There you go. No disagreement. Landmark trial. I love it. Any final comments on these two papers?
I think
they're important to know about, aren't they?
Yeah, definitely.
I think so. And, you know, if you are a trainee out there, you might get a chance to show off a little bit and drop it in to say, well, of course, you know, the SWOG 1011 study, etc.
And the LEA trial.
Yeah, exactly. And the Göteborg one now has 25-year follow-up in European urology. And that's how it works, you know. And I remember when I was a young trainee and you look up at some of the, you know, the stars in the hospital or on the circuit who seem to know all these papers. Guess what? You know, you actually have to start a process of improving your learning. You don't have to, nobody was born with all this knowledge, you know. And I think journal clubs, I've always enjoyed journal clubs for that reason. But journal club on a podcast, there you go. It's, you know, that's a half an hour killed and you got a reminder on two papers. So
it's an easy way to keep you up to date.
Exactly right. Yeah. So look, thanks so much to you, Carlos Delgado, here in Melbourne, who's just joined us from Mexico for a year. And Carlos is going to be one of our two journal club editors, we're calling you, and Dr. Elena Berg in Munich is our other Journal Club editor. So we have already a bunch of papers we've picked out. We're sharing them among the group with Renu and David Chen, our partnership manager. But if you have suggestions, if you're listening or watching to this and you think, oh, yeah, this was a good paper that came out recently, or, I've always wondered why that particular paper from 20 years ago is still talked about, please do get in touch and make suggestions, and we're going to post an episode like this every month. Thanks also to our GU Cast Journal Club partners at MSD, who are great supporters of the podcast, and lots of other educational activities we do. So from you in Germany, good morning and goodbye to you, Elena. Thank you for joining us.
Yeah, thank you for having us.
Great. And from here in the studio, Carlos, thank you for joining us as well.
Thanks for having me here.
You're very welcome. That's all we have time for on this episode of GU Cast. We'll be back again soon.